We've now been at Medicaid Redesign for about 2.5 years. So as opposed to just simply talking to you about plans for the future, I can actually now begin to talk about some of the results, some of the actual steps that have been taken. But I think in terms of where we are at Medicaid Redesign, I also want everybody to understand we have a long way to go. We have a plan. It's really a 5-year plan that we're now just about halfway through implementing. But what's going to happen in 2013 and what's going to happen in 2014 in particular are going to be some very significant steps. And we're going to need really the entire Medicaid stakeholder community to coalesce around those initiatives and work together in terms of making sure that they are a success. But in terms of implementation to date, we set this out when the governor created the Medicaid Redesign team. He really was focused on, sort of twin goals of trying to make the program financially sustainable well into the future, as well as to improve the quality of care provided to Medicaid members. What the governor found when he took over as the governor was that he found that basically 40% of the total state budget was on path to grow by about 13%. That was simply unsustainable. The state of New York taxpayers have been very generous for the Medicaid program, more so than any other state, but that we'd sort of gotten to a point where we needed to find some greater efficiencies in the program moving forward. And on the cost side of the equation, we've made a lot of progress. If you look at, and we put out a press release not that long ago that showed what spending has actually been like since Medicaid Redesign began in January of 2011. Compared to the trend we were on, you will see a very distinct bending of the cost curve. And in fact, for the first time in living memory, in calendar year 2012, we finished the year actually having spent $222 million less in New York City alone than we did the previous year. So the first sort of year-on-year actual reduction in Medicaid spending in New York City, and as I said, probably ever in the Medicaid program. So now that savings has allowed us to do a number of things. First and foremost, it's allowed us to make some targeted investments in areas we think will have long-term benefits for the program, both on the quality as well as on the savings side. One of those areas has been supportive housing. We put basically into the budget in our first phase of MRT, but it really was dollars that became available in our second year, $75 million. That amount now has grown to about $92 million, and we are now significantly into the housing business as a Medicaid program. In fact, we're as far as we know, the only state in the country that uses state-only Medicaid funds to invest in both direct rent subsidies as well as into actual capital improvement projects. In our first year, we provided assistance to basically 5,000 individuals to be able to access housing. There's a lot more to be done, and our hope is as the years go on, we're actually going to expand that program. We want to move that dollar amount annual investment over $100 million, and possibly, if we get a certain waiver amendment approved, multiply that number at least by 2, if not by 3, on an annual basis, and really, on our belief, move the needle when it comes to housing access for Medicaid members. In addition, we have been launching some initiatives that really have been, I would say, disruptive innovation is a good way to put it. Sort of the top of that list has been the introduction of health homes. I say health homes are one of the most challenging implementations we have. Why? Because it really is an example of trying to break down the silos, bringing providers together. When I talk to provider, I mean it in a very broad sense, including housing and human service providers, not only just your traditional healthcare, behavioral health types of providers, trying to get them to really work together as a team, sharing information, trying to coordinate care, and at the same time we're trying to build these organizations. We're also enrolling into them the most complex Medicaid patients there are. And the stat I like to use to give audiences a flavor of who it is that's being assigned to health homes. When we look at the, quote, top 100 in terms of total health care expenditures, Medicaid expenditures, the year prior to their enrollment into health homes, for that 100 individuals, we spent $50 million, $500,000 per person. And almost all of that expenditure was in hospital use, emergency room use. These are individuals with multiple chronic comorbid conditions, significant and persistent mental illness, substance abuse challenges. And our belief is health homes are a unique opportunity for us to try to really coordinate care across these silos to really make sure that those individuals are getting the care that they need. We also have some confidence that as a result of that investment that we're making through health homes, we're going to actually see savings in other areas. But it still remains very much a work in progress, but we're beginning to see some initial results from some of the health homes. In fact, we're beginning to see declines in ER use. We're beginning to see declines in inappropriate hospitalizations, but we're still very much in the early days. I know many of you involved in health homes in some capacity know full well some of the challenges that have been brought, but we are excited by the progress we're really beginning to see. I will leave it to these guys to talk about what I think also is a very exciting, but also will be a challenging implementation. That a lot of work will be done in 2013, but into 2014, and that's the launching of HARPS. Our approach to beginning to integrate behavioral health and physical health across the entire Medicaid program. I think this has, really almost of all the things that we're doing, potentially some of the greatest reward. I know there's a lot of concerns out there about how it's done, and I know we're working very closely with our colleagues from the O agencies to make sure that this integration achieves the positive elements, the things that many of us aspire to, which is better coordination of care, opportunities that when savings occurs to make targeted reinvestments, to expand services to individuals, the opportunity to break down these silos, to get out potentially from under some of the sort of more arcane rules and regulations that have existed and prevented some of the innovation and better care that we all want. But at the same time, I know there's nervousness out there about what it's going to mean for providers, what it's going to mean for members, and that's why we want to work very closely with the stakeholder community as we roll that particular initiative out. And then lastly, I want to mention the Medicaid Redesign Team waiver amendment, which is sitting before CMS. We believe this is also a unique opportunity for us. We are saving not only state taxpayers a lot of money, but we're saving the federal government a lot of money. In fact, in our first year, we saved the federal government $2 billion. That money all went back to Washington, and that amount of savings, based on CBO estimates, was enough to flatline the national growth rate in Medicaid. Our argument to the federal government is that we'd like to keep some of that savings here in New York and allow us to make investments in some targeted areas. We know full well, and I don't have to tell anyone in this room, that we've got some challenges in healthcare delivery. We do not have enough primary care. We have providers who are not yet ready to embrace the new payment systems, the new care models that we want to launch. We do not have the HIT fully deployed as much as we would like in order for care coordination to truly be successful and allowing health home partners to be able to share information. We do not have enough housing supply in the state of New York for the members who desperately need it, and if we can get it to them, we know we can make a measurable difference in the quality of their lives. Those are all areas where we need to make targeted investments. And our argument to the federal government is give us an opportunity. Let us keep some of that money, potentially $10 billion over a 5-year period, here in New York. And there, as a result, we will make even greater strides in achieving the triple aim that CMS and the federal government has locked in on, which is improved care, improved health, and lower costs. And so we remain confident. In fact, lately we've made some progress with CMS on the waiver amendment. We had a small issue associated with the financing for developmental disability system services that had to be resolved first. But now that that system has been replaced, not without some much consternation, that we are now in a position to really engage on the waiver, and we are very excited about some of the recent conversations we've had with CMS.